Every year, millions of people sit across from a doctor, hear 4 words, "You need a surgery," and never think to ask why. They sign the consent form, they show up on the scheduled date, they trust the system completely. And a significant number of them, far more than anyone in that system will acknowledge, did not need to be there at all. I want to be clear about something before we go any further. I am not anti-medicine. I am not anti-surgery. There are operations that save lives every single day, and I have enormous respect for the physicians who perform them. What I am against is the surgical recommendation that exists not because it is medically necessary, but because it is the path of least resistance, because it is faster than a conservative approach, because someone, somewhere, gets paid when you go under the knife. My name is Dr. Sarah, and I have spent years in cardiovascular medicine watching this pattern play out in real patients. People who came in with manageable problems and left with consequences they are still living with. Scar tissue, chronic pain, disrupted circulation, adhesions that nobody documented because formally the operation was a success. Today, I am going to name 5 operations I would not have performed on myself, and if your doctor is recommending any of them, I want you to know exactly what to ask before you say yes. Subscribe if you want the kind of information your appointments were never designed to give you. Let's start. Number 1. Diagnostic laparoscopy. 2 clinical words. Here is what they actually mean. Laparoscopy is a procedure where a surgeon punctures the abdomen, inserts a small camera, and looks inside the abdominal cavity. The word diagnostic tells you the purpose, not to treat anything, but simply to figure out what is wrong. You are being surgically operated on in order to establish a diagnosis. Let me walk you through what that actually involves, because the details are what they will never explain to you in the consultation room. The surgeon drives a hollow metal tube called a trocar through the abdominal wall. Then, because the abdominal cavity is packed with organs, there is no space for the camera to see anything. So carbon dioxide gas is pumped in. The abdomen is inflated from the inside. Pressure inside the cavity spikes sharply. The diaphragm, the muscle that controls your breathing, gets pushed upward. In many cases, the patient is also tilted with their head lower than their feet, so the surgeon can examine the pelvic region. Think about what that means for your body. Over your entire life, your abdomen has never been inflated under gas pressure. The ligaments holding your organs in place are subjected to forces they were never designed to handle. Your pelvic floor is compressed from above. When the gas is released and the procedure ends, the abdomen returns to its normal size, but the tissues remember. Stretched ligaments do not snap back instantly. For weeks, sometimes months afterward, patients feel discomfort, heaviness, a sense that something is off. None of this appears in the medical record as a complication because formally nothing went wrong. And then there is the scar tissue. Every puncture heals through scar formation, not just at the skin, but in the muscle beneath it, in the fascia, potentially in the peritoneum lining the abdominal cavity. Scar tissue pulls. It creates adhesions, fibrous bands between organs that should move freely against each other. Adhesions following laparoscopy are not a rare complication. They are an expected outcome. Here's the part that should make you stop. After all of that, after the puncture, the gas inflation, the tilting, the general anesthesia, surgeons frequently find nothing, or they find exactly what was already visible on ultrasound before the operation ever happened. Modern medicine has high-resolution ultrasound, MRI with multiple contrast protocols, CT scanning, and comprehensive laboratory panels. That is an extraordinary diagnostic arsenal. My position is firm. Puncturing the abdomen is not a diagnostic act. It is diagnostic surrender. Exhaust every non-invasive method first. every single one. Number 2, umbilical hernia repair. An umbilical hernia is the protrusion of tissue, usually a small loop of intestine or fatty tissue, through a weak point in the abdominal wall at the navel, and behind that weakness is almost always one underlying cause, connective tissue that is structurally weak. Connective tissue is the framework of the entire body. It forms ligaments, tendons, blood vessel walls, the fascial wrappings around muscles. When it is inherently weak, problems appear at multiple addresses: varicose veins in some people, hypermobile joints in others, hernias in others. Different presentations, same root. Here is what most surgeons will not tell you about umbilical hernias in children. They are extremely common, estimated at roughly 1 in 5 infants, and in the overwhelming majority of cases, they close entirely on their own by age 5 to 7 without any intervention. The connective tissue matures, the muscles strengthen, and the umbilical ring seals itself. Surgeons know this, and yet operations are regularly offered to children of 2 and 3 years old. I want to be balanced here. There are genuine indications for surgery. A very large hernia opening, one through which a significant loop of intestine can pass, is one of them. The more serious risk is incarceration, when tissue passes into the hernia and becomes trapped, cutting off blood supply, causing tissue death. That is a surgical emergency, and earlier intervention in those specific cases is fully warranted. But those cases are the minority. If you or your child has been diagnosed with an umbilical hernia and surgery has been proposed, ask specific questions. What is the actual measured size of the hernia orifice? What is the documented risk of incarceration in this specific case? Is watchful waiting a medically legitimate option here? If the answers are vague, seek a second opinion, then a third. And in parallel, start working on the transverse abdominis, the deepest layer of abdominal muscle that wraps around the torso like a natural corset. Here is the exercise. Stand upright or lie flat. Draw your abdomen slowly and deeply inward. Pull the navel toward the spine as far as you can. Hold the contraction. Try to deepen it further. Hold until you feel a deep burn in the muscle. Then a slow exhale and full release. Daily. Within a month of consistent practice, the difference is measurable. I have watched patients with abdominal wall hernias respond to this work in ways no surgical consultation ever prepared them to expect. Quick pause. If any of this is connecting with something you or someone close to you has been told, drop a comment below. Tell me which surgery came up in your life. I read these, and your experience helps shape what I cover next. Number 3. Intramuscular injections as routine treatment. I know what you're thinking. A shot is not a surgery, but from a strict medical standpoint, it is classified as a minor surgical procedure. Any intervention that violates the integrity of the skin and underlying tissue meets the definition, and intramuscular injections do exactly that. Here's what happens inside the muscle with every injection. The needle cuts through skin, subcutaneous fat, and penetrates into the muscle tissue. Along the entire path, it is mechanically displacing tissue. Then the medication is injected under pressure, not filling an empty space, but forcibly separating muscle fibers to create a cavity. Then the needle is withdrawn. The body repairs the damage it only knows how: scar tissue. 1 injection, 1 scar. Functionally almost imperceptible. 10 injections, 10 scars. A course of 20 intramuscular injections, and the muscle begins to lose its elasticity. It becomes denser, less pliable, less functional. I worked in settings where patients returned for repeated injection courses over years. Some of them had gluteal muscles that had become literally hard. Getting a needle in required noticeable force. That is not a figure of speech. That is a clinical observation. Oil-based solutions are particularly aggressive. Vitamin D, vitamin E, vitamin A, certain hormonal preparations, these dissolve slowly, sometimes very slowly, sustaining an inflammatory response inside the muscle for an extended period. The scarring from oil-based injections is coarser and more significant than from water-based ones. And then there's the sciatic nerve, the largest nerve in the body, running directly through the gluteal region and governing movement and sensation throughout the entire leg. An injection that contacts it produces immediate sharp pain, numbness, and in severe cases, lasting neurological consequences. The practical rule is simple. If a medication comes in an oral form, take it orally. The bioavailability of modern oral formulations is comparable to injectable forms for the vast majority of medications. Vitamins in capsules work. Antibiotics in tablets work. Reserve injections for situations where there is genuinely no alternative. Number 4. Surgical facelift. The medical term is rhytidectomy. In plain terms, a surgeon makes incisions along the hairline and behind the ears, tightens the underlying muscles and skin, and removes the excess and fixes everything in a new position. The goal is to restore a younger-looking jawline and reduce wrinkles. Here is the paradox at the center of this operation. Every incision produces a scar. Scar tissue does not conduct blood as efficiently as healthy tissue. The skin fed by vessels that pass through a scarred zone receives progressively less oxygen and fewer nutrients over time. An operation designed to reverse aging creates a mechanism that accelerates it, not immediately, but reliably. And then there's the anatomy specific to the face that makes this different from any other region of the body. Facial muscles do not attach to bone the way all other muscles do. They attach directly to skin. That's how we express emotion. And they connect through fascial chains to the jaw, the neck, the trapezius that extends down to the shoulder blades. This is verifiable anatomy. Tighten your entire face right now, as hard as you can. Feel what activates in your neck and shoulders. Now release, and add a gentle half smile. Feel the whole system drop. These chains are real, and they are active. When a surgeon repositions the facial muscles surgically, the tension throughout that entire chain changes. Head positioning shifts, neck muscle tone shifts. The downstream effects on posture are difficult to measure precisely, but they consistently move the system toward disruption. And then asymmetry. No human face is perfectly symmetric, which means the muscles on each side are already operating from different lengths and tension states. A surgeon who performs the procedure with technical precision, geometrically symmetric, may produce a result that looks unnatural precisely because the baseline was never symmetric. One eyebrow higher, one corner of the mouth pulling. These are not rare outcomes. They are frequent enough to be documented systemic risk. What actually works is circulation. Your own arterial blood is the most powerful cosmetic available. It delivers oxygen, nutrients, and growth factors to every facial tissue. What blocks it is muscular tension in the neck, poor posture, chronic stress. Address the cause. Add facial exercises, daily, consistent, and the tissues respond. This is not wishful thinking, it is physiology. Number 5. Cesarean section without medical indication. Let me be direct from the beginning. When the indications are real, placenta previa, true fetal distress, persistent transverse position, a cesarean section is a brilliant operation. I would never argue otherwise. In those situations, it is life-saving. I am talking about something entirely different. Elective cesarean without a specific medical indication, requested because of fear, convenience, or because a physician defaulted to it without documented necessity. Here is what actually happens to the mother. A cesarean is a major abdominal operation. The abdominal wall is cut open, the uterus is opened, the baby is extracted, everything is closed in layers. A permanent scar remains on the uterus, and in every subsequent pregnancy, that scar carries specific risks. Potential placenta accreta, where the placenta grows directly into the scar tissue, and potential uterine rupture during labor, which is a life-threatening emergency. The post-operative recovery is substantially harder than most women are prepared for. After a straightforward vaginal birth, a woman is on her feet within hours. After a cesarean, within a full day, and only with difficulty. Breastfeeding is harder to establish because the hormonal cascade that initiates milk production is normally triggered by the physiological process of labor itself. And then there is information about the baby that most people simply do not have. During passage through the birth canal, something called bacterial colonization occurs. The newborn receives the mother's microflora, the bacteria naturally present in the birth canal, which become the foundation of the infant's intestinal microbiome and its first line of immune defense. Babies born by cesarean do not receive this primary colonization. The research is active and rigorous. Statistically higher rates of allergic disease, atopic dermatitis, bronchial asthma, and gastrointestinal difficulties in early childhood in cesarean-born infants compared to vaginally born ones. If a cesarean has been proposed to you or to a woman in your life, ask one direct question. What are the specific medical indications in this case? If the answer is not specific, find another specialist. Here is what I want to leave you with. After 40, every risk discussed today becomes measurably higher. Connective tissue heals more slowly. Scars form more densely. The tendency to develop adhesion increases. The price of an unnecessary operation rises steadily with age. How old are you right now? Write your age in the comments. I want to understand exactly who is watching this so I can make sure the next videos address the risks that are most relevant to where you actually are. For any elective procedure, do not make the decision in a single appointment. Ask your surgeon directly, what happens if I decline? What changes in 3 months, in 6 months, in a year? If the answer is evasive, take time, get a second opinion, find a third. Look for a conservative approach first: exercise, nutritional correction, physical therapy, lifestyle modification. Many conditions that are classified as surgical stop being surgical under a well-executed conservative approach. Medicine has a principle that stood for centuries: primum non nocere. First, do no harm. The best operation, more often than people realize, is the one that turned out to be unnecessary. The healthcare system is built around procedures and operating rooms. Nobody inside it is structurally positioned to tell you what I just told you. That is why this channel exists. Subscribe. Share this with someone who is currently weighing a surgical decision. You may be the reason they ask the right question before it is too late. This video is for educational purposes only and does not constitute medical advice. Always consult a qualified healthcare professional before making any decisions about your health or treatment. Individual medical circumstances vary, and nothing presented here should replace a conversation with your own physician. And if this reached you, help Dr. Sarah reach 1,000 subscribers, because this is exactly what 1,000 people need to hear.